Okay, here we want to go with the digestive system part two. Okay, second part, talking a little bit about the upper digestive system portion, particularly involving the mouth, the esophagus, and the stomach. Then we'll continue on further on down to the digestive system in some subsequent videos. So let's talk first about the mouth. In the mouth, we know involves the oral cavity with the cheek, the tongue, the lips, the hard palate, and the fauces. The fauces we talked about earlier was basically the pillars that we have on both sides of the back of the throat, right where the tonsils are. Okay, they all have something to do with it. Lips are probably more important in regards to speech than anything else, but the cheeks are important because what happens is, remember our good old friend the buccinator keeps the muscles tight in the cheek to keep the cheek sort of against the teeth, and that way we don't get a lot of food that's trapped down between the teeth and the gums and the cheek inside. So that's that. The tongue is important because what the tongue actually does is it's able to move the food around from side to side so that it gets underneath the teeth so it can be chewed correctly, as well as when I finally have this large bolus of food that's mixed with the saliva from the salivary glands, it could take that whole big ball of material, that bolus, and move it to the back of my throat into the area of the oral pharynx so it could be swallowed. I know my soft and the hard palate are important because what happens is my hard palate basically provides a firm area in which I could press my tongue and all the material that's up underneath there to keep. And also we know that my hard palate is where the root of all the alveolar processes of the maxillary teeth would be. And then soft palate, we know, as we've talked about before, is important because what happens is when it rises, when I swallow, basically a reflex of cranial nerves 9 and 10, like we've talked about a billion times so far, it seals off the back of the nose, so I don't get a lot of stuff going up the back of the nose. Okay, so that tongue is important. A couple things about the tongue is on the tongue, on the bottom of the tongue, if you lift the tongue up, you'll see a band of tissue that connects the tongue to the bottom, and that's called the frenulum, okay, or the lingual frenulum. It's below. It sort of holds the tongue a little bit so it doesn't get too wobbly. Sometimes I remember people in the past used to be said to be tongue-tied, where that frenulum was very tight and very short, and as a result sometimes they just go in and snip it and be fine, stuff like that. And we should also mention the tongue has all the taste buds on there. There are sensory receptors we talked a little bit about in the nervous system. The teeth, there are multiple parts to it. The crown, which is the top, the root, the neck regions, which are all part of the teeth. The crown, the top, the neck, or the root and the neck regions. You can all look at the diagram on the bottom. And the outer shell of the tooth is called the enamel. That's the harder area that gives the teeth a good amount of firmness. As people get older, the enamel gets worn away just by chewing. Well, that will happen, as well as a lot of acids. People, when they drink a lot of stuff that's more acidic, it will cause that to be eroded away. Meth users, I always talk, I know they're a meth user. Why? Because their teeth are all rotted. Because what the meth does is an acid, and it actually wears away the enamel. Underneath the enamel, we have what's called the dentin, which is the basic bulk of the tooth. And then deep inside the tooth, we have the pulp cavity, which in that pulp cavity, basically the nerves and the vessels are inside there. And then from the pulp cavity extends down towards into the root, which is that root canal. The teeth are actually cemented in place. We talked about how osseous-wise, they're in both the mandibular and the maxillary alveolar process. Those small, like multiple little air holes, like all in the bone there. But what happens is the gums are in there, and there are small little ligaments which will actually hold the teeth in place. When they have to take a tooth out, they usually go in around the outside of the tooth and actually sort of like rip away all the ligamentous structure that allow the tooth to be able to move. Okay, just for the sake of discussion, there's 20 deciduous or baby teeth and 32 permanent teeth, but that's not a big deal. Probably what's more important is my front four on the top and the bottom four on the bottom four on the bottom. Basically, they're called incisors, and they're there because they incise, they cut. Okay, sharp edge, they cut down on things. If you have to rip something or cut something off, you use those front teeth, those incisors. Okay, the ones that are next to it that hang down like fangs are called the cuspids of the canines, and they're terrors or rippers. You see dogs, they have these huge big fangs, and basically the canine teeth, and they're for ripping and stuff like that. You see a dog ripping things apart, So those are called the canines, and they're rippers or tears. The ones in the back are called bicuspids, premolars, and molars, and basically basically, they're flat top with little bumps. They're basically for grinding. So I could grind things in the back, I could cut things in the front, and I could rip things from the, sort of like in the junction between those two. And that's what we have in the oral cavity, okay? Also in the oral cavity, really important are the salivary glands. Now, we have 3 sets of salivary glands in the mouth. The first one we've talked about before, especially with the muscular portion, when we talked about the muscles of facial expression and the muscles of mastication, is the one that's at the angle of the jaw. That's called the parotid gland. When people have mumps, it's called infectious parotitis, where they actually have a viral infection that involves the parotid gland. When we talked about the important thing about the parotid gland is it makes both saliva as well as salivary amylase, which actually starts to break down starches inside the mouth. And if you look at the picture on the right, you can see the parotid gland with the duct. Now, we talked about that duct because what happens, it comes over the surface of the masseter, and finally when it gets to the anterior edge of the masseter, it cuts straight inwards, cuts to that buccinator, which is the one inside the cheek, and exits opposite the second upper molar. So hopefully last time when we talked about that, you were able to look inside there and see where that area of the duct from the parotid gland would empty into the mouth. We also have sublingual glands. If you lift up the bottom of the tongue, you'll see that when you see that frenulum, on both sides of the frenulum, right along the floor of the mouth, you'll see these little dots with little holes in the center of them, and those are my sublingual glands. And sometimes if you just lift up your tongue, they just automatically squirt when they're all full, because they do make a lot of saliva during the course of the daytime, okay? And then the submandibular glands are also on the floor of the mouth, but they're more towards the edges. Sort of like just inside the teeth. If I look at the lower molars, there'll be some bumps just inside the area of the lower molars on the floor of the mouth, and those are my submandibular glands. The sublingual and the submandibular glands mostly just make saliva, where the parotid gland makes the saliva as well as the salivary amylase. And the thing that's important about the saliva is that when we chew things up and break it down, and it's called mastication, muscles of mastication, called mastication. When we grind things up, what happens is the saliva is able to keep it and sort of like hold together like in a ball, okay? So what happens is then the tongue could actually lift it up and move it to the back of the throat to be able to swallow it into the posterior, into the area of the oral pharynx, okay? So basically that's what the saliva does. It sort of holds things together. If you wonder about the value of saliva, just take a bunch of crackers, regular soda crackers, and take a bunch of them and just eat one after the other, but don't swallow. Just take a whole, put about 10. All of a sudden what they do, they suck out so much of the water you can't swallow because there's all these crackers in your mouth, and there's no saliva to sort of like bind it together, because that bolus is really important to be able to have the tongue move it to the posterior aspect of the oral pharynx, at which time it stimulates that cranial nerve 9 and 10, so the soft palate rises, and I push that bolus to the very posterior aspect of the posterior pharynx, and then from that point the muscles in the esophagus and the posterior pharynx will contract to bring the food down, and then it starts to squeeze, getting the food on down the area of the esophagus, okay? Again, we make probably about a liter and a half of saliva per day, and to be truthful with you, most of it's water, okay? We have other things in there like electrolytes, like sodium and chloride and bicarbonate and stuff like that, buffers, some lubricants like a mucin, which is lubricant, some antibodies, enzymes, waste products, but again, about 99.4% water, so almost all water. About 70% of it comes from the submandibular glands on the side, about 25% from the parotids, and about 5% from the sublingual. Don't remember the numbers aren't really important. I think the important part is we have these 3 glands that will make saliva to get things into a ball, okay? Again, and what's the function of the saliva? It lubricates what we eat, okay, and moistens it. Also, because of the amylase from the parotid gland, it's a dissolving chemical. We actually start digesting starches, in your mouth, which actually begins as we go further on down the gastrointestinal tract. What controls the salivary control? The autonomic nervous system. And which part of the autonomic nervous system? Obviously the parasympathetic. And again, time and time again, we're going to mention that what happens is the parasympathetic system drives the gastrointestinal tract. Most of the things that stimulate the gastrointestinal tract are going to be parasympathetic. We talk about in other organ systems, with probably the exception of the bladder, but if we talk about the other organ systems, what stimulates it is probably the sympathetic nervous system. However, what stimulates the gastrointestinal system is the parasympathetic nervous system, just the opposite from what we see in other places, okay? So what happens in the mouth? Again, the teeth mechanically break down the food and they rip it up into small particles, and then the tongue aids in the swallowing. The process of swallowing is called deglutition.
deglutition. So if you hear something with deglutition, it means swallowing. Okay. Again, chemical digestion begins in the mouth because the salivary glands will make this with the saliva moisten things together, but we do start to digest starches and some other simple sugars by the amylase that's in my mouth. I kind of ASE, enzyme amylo. Starch, so it starts to break down the starches in the mouth as well. Okay, and the picture on the right shows what happens is how that bolus is made, and the tongue takes it and pushes it to the back of the oropharynx. And at that point, they let the reflex of cranial nerves 9 and 10, glossopharyngeal and vagus nerve, stimulate the muscles that are actually going to start having that food move on down the esophagus. Okay, and that's what happens in the mouth. Some oral processing controls. Again, the nervous system that controls the salivation are parasympathetic fibers that go along with the facial nerve, cranial nerve 7, and the glossopharyngeal nerve, cranial nerve 9, like we talked about. And a lot of this is stimulated by things such as sight, smell, sound, and memory of food. You think about food, all of a sudden your mouth starts to water. And basically that salivation is sort of like almost involuntarily produced just because I could smell food, or if I could see food, or get a picture of food, or the sound of food, you know, things, bacon bubbling in a pan, I don't know, or just even thinking about food. So when you start to get hungry and all of a sudden, you know, your mouth starts to water, and basically that's the autonomic nervous system, or fibers from the autonomic nervous system, primarily parasympathetic through cranial nerve 7 and cranial nerve 9 that do that. Okay, deglutition, or swallowing, is a little bit more complicated than that because it involves a couple things. Okay, a lot of it, and most of the autonomic portion, comes from the area of the lower portion of the pons, but primarily the medulla oblongata, like we talked about before. There are really 3 phases that we get with swallowing. One's called a voluntary, and voluntary is basically I could chew things forever. I could sit here and chew away the cud and stuff like that forever, and then finally I'll say, okay, it's time to swallow and push it. So that's more of the voluntary portion, and basically that's taking and chewing the food, which I have control over. That doesn't occur, you know, by the autonomic nervous system. I'm actually mechanically doing that through cranial nerve 5, okay, muscles of mastication, like we talked about before. And what happens is, and then using my tongue, which is cranial nerve 12, okay, and pushing it to the back, and that's, I have control over that. Once I get back there to the back of the throat, I can't control it after that. That becomes involuntary, and that bolus, once I get to the back, all of a sudden now we have autonomic nervous system fibers from like 9 and 10 and on down that will actually help with the muscles that will start to squeeze to be able to get things down through the posterior oropharynx down the esophagus. And then when we finally get in the esophagus, that's totally involuntary. Things go down the esophagus for a couple reasons. Number 1, volume. So in other words, the volume is pushing things down. Number 2, gravity. If you're lying down flat, it's much more difficult to eat, okay? Or if you're upside down, you try to eat when you're hanging upside down from your feet, like from a, you know, one of those little suspension boots or something like that. It's not going to happen very well. So gravity helps, but what really helps a lot is that parasympathetic activity with the squeezing in a rhythmic fashion that will actually squeeze on down the esophagus to move that bolus from the mouth at the top of the esophagus all the way down to the stomach. Okay, what else happens in the stomach, or what else happens in the esophagus? Not a whole lot. Okay, the esophagus is about 10 inches long. Okay, and we talked about this when we talked about the respiratory system. The anterior portion of the esophagus is actually attached to the posterior aspect of the trachea. There's fibrous tissue or connective tissue that hold the two together. Okay, in most cases when we're not eating, the esophagus is pretty much closed. Okay, unless I swallow, the esophagus is closed. It's closed from front to back, so it's flat from front to back. Okay, and like this. Okay, front to back, it's flat. If I swallow, it's going to open, and the peristalsis is going to start to move things down the esophagus. Okay, and basically what happens is the esophagus is basically that connection from the laryngopharynx all the way down through the stomach. It goes through what's called the esophageal hiatus, which is actually an opening in the diaphragm, and the muscle. It's sort of interesting. The muscles in the opening around the diaphragm, they sort of cross over each other this way. So as a result, when the diaphragm contracts, it actually sort of like tightens up the muscles. So we have both a sphincter around the area of the esophagus, but also the diaphragm will assist as well in closing off the esophagus from when it gets down to the area close to the stomach. Okay, so we do have that. We also have sphincters, again, upper and lower sphincter, to prevent backflow or reflux. What we're going to see in a couple minutes is once I get stuff in the stomach, and once I start getting that digestive process going in the stomach, there's a good amount of acid that's produced. And the idea is you don't want to have the acid coming up the esophagus. So you need these sphincters to be able to hold the bottom portion of the esophagus closed, so that what happens is the acid doesn't go from the stomach up into the esophagus, which if it does causes a lot of burning. I'll talk about that as called GERD in a couple of minutes here. Okay, and so basically what really happens in the esophagus, again, not a whole lot. There's no digestion or absorption that's been initiated in the esophagus, because we know we have digestion, absorption, and then elimination. It's basically a conduit. That's all it is. It's a tube. The only digestion that occurs is what's started in the mouth by the salivary amylase from the parotid gland. That's about it. Okay, and what happens is in the mouth, that the bolus that we have inside, once we leave the mouth and we get down the esophagus, the bolus that we have of the food moves on down by peristalsis. Now I mentioned peristalsis was because of the firing of those muscular nerve endings, autonomic nerve endings that go to the muscles in that third layer of the GI tract that will squeeze, and they squeeze in an order. When you feel your stomach growling and stuff like that, that's the peristalsis, which is actually moving things around. Okay, again, if that lower esophageal sphincter doesn't close, and you can see the picture on the right where it says the lower esophageal sphincter, if I'm not swallowing, if there's nothing in the esophagus, that sphincter is closed, or it should be closed. Okay, on the other hand, once I'm eating, that sphincter will open, so that things, when they come down the esophagus, they'll plop right down into the stomach. They'll drop in there. If there's a problem with that sphincter, okay, what happens is then the gastric acid, like I mentioned, leaks up, and it starts to burn the lower portion of the esophagus, which is called GERD, gastroesophageal reflux disease, reflux moving upward. Then they get that heartburn. I'll talk about that. I'll show you a little picture in a second about what happens with that. There's another condition which happens very unusually in the esophagus. It's called achalasia. And what happens is we find that in achalasia, the muscular control in the lower portion of the esophagus doesn't work very well, okay? And as a result, the sphincter doesn't open. So as a result, they'll eat, but they always feel like there's this big ball of food in their chest because that sphincter doesn't open. And that's the problem with that muscular plexus, that myenteric plexus, that actually helps to control the relax and contract the muscles. And these muscles are constantly held in a state of contraction, okay? There are certain medications that they might be able to use with that, okay? Now this is basically what we're talking about with GERD, okay? It's interesting because what happens is we talked about how when we get in the back of the throat and down the esophagus, the cells that we have are squamous cells. They're stratified squamous cells. They're flat cells. However, when I get to the stomach, or just above the stomach, the cells will change. They change because what happens is I have to have glands inside the stomach. And again, like we've talked about a couple times, if I need glandular structures in the tissues, I have to have higher levels of cells. I can't have flat, very thin cells. I have to have a high column of cells so those glands could sit in between. Okay, so as a result, what happens is we find right at where the esophagus is getting ready to empty into the stomach. Okay, you could see it on the picture on the left. It says the squamo-columnar junction, and actually, if you take a tube and look down, you will actually see a red line where that change occurs. Everything above it is simple squamous. Everything below it is columnar cells. What happens though is if you look, and you can see that up in the picture, up in the upper left, okay, and that's basically where that line is, which is pretty well designed. Okay, it's called the dentate line or the Z line, right where the change of squamous cells to columnar cells occurs right there. And you can see how the tissue's puckered. That's right where that sphincter is. That sphincter sort of puckers that area right there. And you can see that's right where it's going into the stomach. You're still in the esophagus in the picture in the upper left, but once you get through that little puckered area, then you're in the stomach. If I look at the picture on the bottom right, what happens if I have a lot of acid that leaks up from the stomach into the esophagus? It burns it. It burns it and burns it and it burns it and burns it. It's a chronic burning that will happen because the acid leaking up in there. Okay, worse at night because you're lying flat, and therefore if the area stays open, the gastric acid could just leak out of the stomach and fill the esophagus. Okay, what it does, it starts to cause a cellular change. If you look at that picture, see it says tongue of Barrett's esophagus. What Barrett's esophagus is it's a cellular change that starts to occur in the lower portion of the esophagus, where it says Barrett's esophagus in the left picture on the bottom, and it's right there at that Z line. And you see how that part comes up like a little finger comes up, and at about you see that about 12 o'clock, and you see that about 3 o'clock on there, and that's the cells are starting to change. In other words, the cells are no longer squamous cells there where they should be, and they're columnar cells. So they're abnormal cells in the wrong spot. Okay, and the problem with the Barrett's esophagus is once it's there, it's a precursor to the development of esophageal carcinoma. The problem with esophageal carcinoma is often by the time it's diagnosed, because it takes about 2/3 to 3/4 of the esophagus to be closed off before people start to get symptoms. When people start to get symptoms, it's frequently too late. It means that there's not a really good capsule around the esophagus, so the cancer has a tendency to spread out of the esophagus and go to the tissues all over the place very rapidly in esophageal cancer. I don't think anybody that I've known that's had esophageal cancer survived much more than a year, year and a half, 2 years. Okay. So that's a little esophagus. Now let's get down to the stomach. Now the stomach has a bunch of parts to it, and again, I wish my thing would be working, but oh, wait a minute, maybe I just got it went on. Let me see. Nope, it's still not working. Let me see if I could do it. Yeah, I could do it with my finger. I can't use my little pen here. If we look at the stomach goes from there to there. Let me do a different color. Okay. Well, maybe I won't do a different color. Yeah, I will. There to there. Here's the esophagus coming down here. Okay. This is the stomach. Now what happens is this little area up in here is called the fundus. That's called the fundus. When you get a chest x-ray, and an upright chest x-ray, sometimes you'll see like a sideways D, which is actually the air bubble, because what happens is this area right here, sort of like any gas in the stomach will rise. And when the gas rises, it fills that little air bubble. So sometimes you'll see a little gas in the stomach, and you'll see a straight line, and it's humped up, and it's going to be darker. Why darker? Because it's gas, okay? And that's because we have gas in the area of the fundus, okay? So get rid of the fundus. Whoops, I didn't want to do that, okay? Anyway, that's the fundus. I'm going to have, it won't, these things won't let me go back for some reason. I'll just draw it on here. So I see my fundus. This is the fundus, would be right in here. This area right here, let me do it a different color, okay? Well, it's not doing a different color, come on. This area right here would be called the cardia. And it's right where the stomach sort of like flares out. So the diaphragm is going to be right here, okay, and right there is where it flares out. This area in here is called the body, okay. And this area right here is called the pylorus. It's sort of like a funnel, okay. So I have my fundus, I have my cardia, I have my body, and my pylorus. I could also look at it this way, okay. This area right down here, because it's a big curve, is called the greater curvature, and this area right here, because it's smaller, is called the lesser curvature, okay? So greater curvature down here, lesser curvature here. This right here, there's also another sphincter right there, and that's called the pyloric sphincter, because this area right here is called the pylorus. This is the pylorus right there. I got a P maybe. Right there, okay, that sounded bad, but there's the pylorus that sits right there. It sort of comes into a funnel. When things are churned and mixed up inside the stomach, they eventually have to be squirted out. When I get food in the stomach, what happens is that upper esophageal sphincter, let me see if I can erase that. There it goes, okay. When I get food in the stomach, okay, the upper esophageal sphincter closes and the pyloric sphincter closes, okay? And inside the stomach, you can see it over here. See these little wrinkles? Little wrinkles over here? Little wrinkles? Those are called rugae. And the stomach has all these rugae, and they're the inside folds. And what they do is when the stomach is able to expand, depends upon how much I eat, the stomach is going to get bigger and bigger and bigger. Because I have these little wrinkles on the inside, it allows the stomach to expand in size. Sort of like those little squinchy things that girls have in their hair, and when you're not pulling on them, they're all wrinkled, but you pull them and you pull them out that way, and they become really smooth. Okay, so that's there. So basically, I get stuff in the stomach, and this upper esophageal sphincter, okay, my lower esophageal sphincter, right where the esophagus meets the stomach, and that pyloric sphincter close off. And so it seals off both ends of the stomach. Then it lets the stomach do its magic, which I'll talk about in a second, okay? So I control the outflow by that pyloric sphincter closing off. What we find is in babies sometimes, in neonates, you know, first couple months of life, what happens is sometimes that pyloric sphincter is so darn tight that there's not much of an opening to be able to go from the stomach into the first portion of the small intestine, which is called the duodenum. And what happens is mom feeds and being a good mom, oh, no, nice baby, and all of a sudden the baby is getting bigger and bigger, and all of a sudden gets a little cranky, and next thing you know, the kid pukes like it's been on The Exorcist. It comes out like in a big stream, you know, knocks down cats, breaks windows, whatever the kid, comes straight out. It's called projectile vomiting. And basically, it's because that sphincter is really tight. They could get around that a couple ways. They could wait for the kid to get a little bit older and just only have smaller feedings, more feedings, but smaller feedings so they don't overload the stomach. Or sometimes they could actually go surgically in, make a small little cut over the area of the pyloric sphincter, go in and just trim a few of the muscles, loosen it up to let that pyloric sphincter open. Okay, so that's there. That stomach has muscular walls, okay, which provides that rugae type of appearance. And there's probably about 4 layers of muscle in there. And the interesting thing is they run in different directions. They have an inner layer which is oblique, but then all the other layers, they're on top, one on top of the other, on top of the other, on top of the other. They run in different directions. So just think about it. If I have 5 different directions of muscles firing, and they all fire at the same time, well, it creates like a kneading action of the stomach, which is actually pretty cool. And that's what actually holds things in the stomach to be able to sort of mix it up. So there's a lot of mechanical mixing in the stomach because these muscles, they're going in different directions, are all firing at the same time, and it's sort of like it's not coordinated. If you talk about a muscle, a skeletal muscle, it shortens and shortens and shortens. What happens is this is all these muscles, these smooth muscles going in different directions that allow that kneading action of the stomach, which is one way that they actually mechanically start to digest even more. Okay, so that occurs in the stomach. A couple things in the stomach too. I mentioned the cells in the stomach they become columnar, and they're columnar because they have to have glands between these cells. Okay, and they had these little crypts. Okay, the crypts of Lieberkühn, stuff like. They have these little crypts in the stomach wall, but there are a number of different cells that we have in the stomach, and I'm going to different types of that line these pits. Okay, these little pits in the stomach wall, and the pits are lined with all these different types of cells that do different things. We have what are called chief cells, okay? And chief cells are basically cells in the stomach lining or the stomach wall that make what are called pepsinogen and lipase. Lipase does what? Lipo, fat, ACE, enzyme, it starts to digest fats, and then pepsinogen is a material that will actually start to break down proteins. Proteins are a real devil to break down because they're really structurally very tight and firm. Okay, we also have in the stomach what are called parietal cells. Okay, now these parietal cells basically are important because they produce hydrochloric acid. Okay, so they make this hydrochloric acid, and they're under the stimulus of the vagus nerve. The vagus nerve has little branches that actually goes to the surface of the stomach. You can actually see them in the stomach, and when it gets to the surface of the stomach, they branch off into multiple areas, and they actually provide an innervation to the area of the parietal cells, and the parietal cells then produce gastric acid, which is a hydrochloric acid. We also find that these parietal cells make something else, which is called intrinsic factor. Now this is really bizarre. Okay, vitamin B12, we get it in leafy vegetables and stuff like that, is important for nerve health. It's very important. Okay, so we need this vitamin B12 in our diet. Some people take vitamin B12 supplements and all kinds of stuff. But we need this vitamin B12 in our diet. It helps nerve regeneration. A good nerve health requires this. Well, what happens if I take food that has B12 in it, if I stick it in the stomach acid destroys it. Absolutely destroys it. It's no good. But what happens is the stomach creates something else. It says, okay, parietal cells, you make the hydrochloric acid, but we do need that B12. So what the B12 does, or what the parietal cells do, is they also make something called intrinsic factor. So when we eat food like leafy vegetables with B12 in it, the intrinsic factor that's also made by the parietal cells binds to the B12, okay? Binds to the B12 as it's getting broken away from all the material we're eating and protects it. It's like a safety shield around. It's like Star Trek put up the shields, you know, Scotty, and what happens is they cover the B12 with this shield. Now it can't be broken down by hydrochloric acid. And finally, when it gets down through the intestines, it goes through all the intestines until it gets right to the end, almost to the end of the road in the small intestine, in the ileum, just before the ileum empties into the large intestine. And there are receptors down there that will bind to the intrinsic factor. When the intrinsic factor binds to these receptors, it releases the B12, and the B12 is absorbed in the last portion of the small intestine. Pretty cool. Okay. We also have mucus cells in there. The mucus cells, guess what they produce? Mucus. Okay, so they keep the stomach mucousy, and I'll talk about that in just a second. We also have G cells, and G cells produce a hormone which is called gastrin. I'll talk about that in a couple minutes. The mucus is really important in the stomach, and the mucus needs to be done simply because, think about it, if I have hydrochloric acid, it's a really strong acid, and stick it in a container, i.e. the stomach, what's the tendency? It's going to burn the esophagus. Why doesn't it burn the stomach? Because the stomach, through these mucus cells, makes a real thick, gooey mucus. And that mucus lines the inside of the stomach that protects the stomach from the stomach acid. Now here's a problem. What's needed to be able to make the mucus is a certain type of a material called a prostaglandin. Okay? The prostaglandins are needed. And what happens is there's all kinds of prostaglandins. Okay, and there's prostaglandin E, prostaglandin G, prostaglandin F, all kinds of different prostaglandins. And they do a lot of things. There are some good prostaglandins and there's some bad prostaglandins. There are good prostaglandins that keep the airways open in the lungs. Good prostaglandins make this mucus. Bad prostaglandins cause pain. So when people have pain, what happens is the body at the area where there's inflammation produces some of these bad prostaglandins, and these bad prostaglandins actually result in the pain. There's these receptors. I think we talked about in the nervous system. What they do is they stimulate these nociceptors, and the nociceptors result in producing some pain. Okay. Well, here's the problem. So somebody has like an inflammation, and the doctor says, "We'll take an anti-inflammatory. Let's give you some Motrin." I have no problem with Motrin. Motrin's a good anti-inflammatory. Naproxen's a good anti-inflammatory. There's a number of good anti-inflammatories out there, and I used to use a lot. As I got older, I used fewer and fewer. I used other things, but they're still good. But here's what the prostaglandins do. The prostaglandins decrease inflammation by decreasing the anti-inflammatories like Motrin, naproxen, Advil's a Motrin, Aleve is naproxen, and stuff like that. What the nonsteroidal anti-inflammatories do is they decrease the production of prostaglandins, but they're not selective for decreasing just the prostaglandins that cause pain. They also decrease gastric prostaglandins. So if they decrease gastric prostaglandins, what happens is the mucus cells don't make mucus. So as a result, then there's areas in the stomach that are not protected by the mucus, so the acid starts to irritate them. That's why people who are taking aspirin, who are taking Motrin, Aleve, stuff like for a long time, not Tylenol. Tylenol is not in this group. But all those anti-inflammatory drugs, when they're taking these anti-inflammatory drugs, they say don't take it too long, because if you do, you're going to start to get some gastric upset. Why? Because it blocks the production of the mucus, because it blocks the prostaglandins, which are needed to make the mucus. Okay. One other thing I should mention about the mucus cells in the stomach is people used to, with ulcers, they used to always blame it just on gastric acid. And guess what? Gastric acid is not always the total culprit. There's a little bug that's in that gets inside, that's in most of our GI tracts. It's called H. pylori. Helicobacter pylori. It looks like a little pickle with whiskers. And what happens is the H. pylori bug loves the mucus. And what it does is it takes this little self, this little pickle self, and burrows itself down in the mucus. Okay? And what happens, it gets down to the lining of the stomach through the mucus and takes those little feelers on there and digs them into the wall of the stomach, so it becomes attached. Well, so big deal. So I got this little bug that otherwise doesn't, that all of us probably have some, that buries itself down in the mucus. Here's the problem. When it gets down there, it says, hey man, this is a nice place. I like it. I want to stay here. And what it does, it starts to do some metabolism within that H. pylori, and it releases an enzyme called urease. urease, and the urease destroys the mucus. Then all of a sudden, all of his friends come over and says, "Hey, you like it? Must be good for us too." And they bury and they stink their little feelers in there, and they start to make more urease. And as a result, all this urease destroys the mucus, and therefore, what happens? It causes ulcers. That's why what you see nowadays, people who have ulcers, yeah, they do try to control the acid because that's going to be really important in letting that ulcer heal. But more than 50% of the people, they also will take an antibiotic. Say, why would they take an antibiotic for an ulcer? Because the H. pylori, they kill the H. pylori in the stomach so that won't destroy the mucus. So when they get rid of all the, when everything gets back to normal and they control the acid, they could heal the ulcer. So that's a little bit of information that you have. In fact, what they could actually do is they could do a breath test. Okay, they could have people exhale, and what happens is they exhale. If there's this urease that's produced by the H. pylori, it comes up in when they exhale because some of it's coming up from the stomach as well, and it basically causes a reagent to cause a change, and it shows that they have the urease. And where's the urease coming from? The H. pylori bug. Okay, so anyway, that's a little bit about some of the secretions. We'll talk about gastro in a minute. Okay, a little bit about gastric physiology too. It's both mechanical and chemical processes to be able to digest, and the stomach is basically very little absorption. There's only a few things that are absorbed in the stomach. A few medications might be absorbed in the stomach, and another big one, alcohol. Alcohol is absorbed in the stomach. That's why people get drunk faster than they get full. Okay, I had a friend who, when I was in high school, whose dad every Friday and Saturday night liked to go out and sit at the bar, sit at the same bar stool, and before he left to go to the bar, we'd know he was ready to go. He'd get all duded up and all the aftershave and everything. And what happens? He'd go to the refrigerator and pull out a stick of butter and eat a stick of butter. And he thought that was going to coat his stomach so it would prevent him from getting full and drunk. Guess what? Usually at 2 o'clock we got a call from the bar saying, "Hey, can you come and pick him up because he's not no condition to drive. Bring him home, throw him to bed, and stuff like that." So anyway, so that's a little bit about the stomach with the alcohol. So not much is absorbed in the stomach besides alcohol and maybe a little water and maybe a few drugs that are absorbed in the stomach. But the stomach is involved in mechanical digestion, and that's where we talk about those muscles moving and churning things up. We also talk about chemical digestion using various chemicals. Obviously, the hydrochloric acid is a strong acid that's going to start to break apart the proteins that we eat, as well as pepsin is going to also start to break down proteins into peptides. And what are peptides? They're small chains of amino acids. And what are proteins? Long chains of amino acids. So I take long chains of amino acids and break them down to small chains, which eventually get broken down to single amino acids to put in our amino acid pool. There's also gastric lipase, which is basically helping to digest fats, as well as lingual lipase. There's a little lipase that's produced, but it doesn't really work in the mouth. Okay, it has to get down and be activated in the stomach. Okay, that's a little about the gastric physiology. Again, that gastric mucosa is protected by that mucus layers, which is basically stimulated by these prostaglandins like we talked about before. What the stomach does is when it starts to, it'll hold food in the stomach for a good amount of time. It'll be there for a long time. And they always talk about the fact that, if they find like a murder somewhere and they want to try to get the time of death, they always gather the stomach contents because things will digest faster than other things. It's very gross, not gross like an ugly gross, but gross in regards to a wide time frame. It's not very specific. Better thing is to be able to test liver temperature according to and compare it to the ambient temperature and how fast the body cools normally after death. What happens is once the materials in the stomach it's reduced to something called chyme, which is sort of like a soupy liquid. Okay, and so this chyme, because of things being digested mixed with the hydrochloric acid and other juices in the stomach, makes this chyme. When the chyme is finally ready, that pyloric sphincter says, okay, it's time for delivery. The pyloric sphincter opens, and what happens is the chyme then is able to be squirted from the stomach through that pyloric sphincter, up the pylorus, that funnel, up the pyloric sphincter into the first portion of the small intestine, which is called the duodenum. The duodenum is very small. It's only about maybe 9 to 12 inches long, and that's all. Again, like I mentioned before, that the stomach really doesn't absorb a whole lot. A little bit of water, some electrolytes, Alcohol, that's a big one, and again, some drugs like aspirin. Aspirin could be absorbed. That's one of the problems with aspirin. And besides aspirin blocking the prostaglandins, aspirin, and this is another thing, most anti-inflammatories, all of them except maybe one or two, they're all acids. So they add to the acid nature of the stomach as well, okay? And the aspirin has a high incidence of ulcer production as well as gastric bleeding. Why? Because it's absorbed in the stomach readily, okay, and it also decreases the mucus production. So it has a lot of factors, and it's also acid. So it's nasty. I take one aspirin a day, but it's only for to work against the platelets. Aspirin is not really a blood thinner. But what aspirin does is it decreases the stickiness of platelets, so platelets don't stick. And if platelets don't stick, that's the first process of a clot. So if I don't let the platelets stick, the chance of forming a clot go way down. And that's why people who are after a certain age should probably be taking aspirin just to help to decrease the platelets from sticking together. Okay. There are a couple phases in regards to gastric control. There's what's called a cephalic phase, a gastric phase, and intestinal phase, and they all do different things. And they're both under neural as well as hormonal control. Some hormones will control this as well as neural impulses for the autonomic nervous system. So let's talk about the cephalic phase. The cephalic phase is the first thing. That's when you start to see food, smell food, hear food popping in the skillet, think about food, and what it does is it starts to get the parasympathetic system up and running. It starts to get the motor churning so we can start to get everything ready. It's telling stomach, hey, get ready, shipment's coming really quick, you know. Sort of like Amazon Prime, you know when the shipment's coming because it's, you know, you get a message. So anyway, that's the cephalic phase, okay, and basically it's trying to get things ready, okay. So that's called the cephalic phase. The second phase we have is called the gastric phase, okay? Now what happens is when I start to eat food, a couple things happen. Number one, first of all, there are sensory receptors. We talked about how the sensory receptors in the second layer, with the mucosa and the layer above that, will detect stretch, okay? So these stretch receptors in the stomach detect the stomach getting larger and stretching out, okay? And what they will do is they stimulate that submucosal plexus to be able to stimulate certain hormones and digestive juices, as well as stimulate the actual mechanical action of mixing, the peristalsis, okay? So basically the stretch receptors, as well as some chemoreceptors that detect acid changes and stuff like that, they get the ball rolling. They start to, they cause the stomach to start to, and this is basically, we get food in the stomach starts to stretch. When they start to stretch, it causes these receptors to send signals to all these little glands to say, secrete this, secrete this, secrete this, secrete this. We need more acid. Well, actually, in the cephalic phase, we're actually getting the hydrochloric acid by the vagal stimulation that stimulates the hydrochloric acid secretion from the parietal cells in the stomach. What happens is things are starting to mix, and we're starting to get more juices in there. We also have G cells. We talked about that before, and that was the last thing on that list. They secrete something called gastrin. Now, gastrin is also a hormone. So when the G cells are stimulated in the stomach, what the gastrin also does, besides the stretch, it stimulates the production of these gastric juices. It does a couple other things which are really important. Number one, it closes the lower esophageal sphincter, okay, and closes the pyloric sphincter, and increases the intestinal motility. Well, you say, why would it increase the intestinal motility? Why don't I want to wait to get the stuff in the intestine till I want to let those contractions occur, okay? So, but it does increase the intestinal motility, and I'll explain why in just a second. Also, it relaxes the sphincter. Later on, it's going to relax the sphincter later on, but not initially. But the ileocecal sphincter at that time, the one between the small intestine and the large intestine. And the reason why it increases the intestinal motility and releases the ileocecal sphincter is because it says, hey, a new shipment's coming from the stomach. Let's get rid of what we have in the intestine now. Some people have what's called a gastrocolic reflex. They eat, and as soon as they eat, bam, they got to run to the bathroom and eliminate everything that's been in the GI tract, that's in the lower GI tract. Why? They want to make room for what's going to be coming. Okay, I know that I have two sisters who've had bariatric procedures. Okay, and most of their intestinal length has been shortened. When they do bariatric surgery, what they do is they tie off most of the stomach, remove most of it, and they attach the stomach way down the tract, way down the intestines. Therefore, if I don't have this long intestinal system a long tube to go through, and the tube is much shorter, they absorb less. What happens is because it's less, they eliminate really fast. So like at Thanksgiving, I learned a number of years ago that I should eat first and eat fast, because if I don't, if they eat in my family room, where you usually put out big enough area to put tables out, that they're running to the bathroom as soon as they eat, which I lose the smell of turkey. So as a result, that becomes a little bit of a problem. Okay. So anyway, the G cells produce the gastrin that stimulate the gastric juices, as well as they tell everything down the intestine, hey, let's get rid of what we have, because there's going to be another shipment coming down the pike. And that's the gastric phase. Then we have what's called the intestinal phase. And in the intestinal phase, now the pyloric sphincter opens up, okay, at this point, which is at the end of that gastric phase. At the end of the gastric phase, the pyloric sphincter will open up. And basically what happens is it opens it up, and now we have the material that's been in the stomach, that chyme, now goes from the stomach out into the first portion of the small intestine, which we know is called the duodenum. The duodenum, like I said, is really short, and it's like a little C. It's a little C that's pointed with the open area pointed towards the left. And I'll show you that when we get to the next video. And what also happens when that opens up, when that pyloric sphincter opens up, it triggers the release of a couple other things. Gastric inhibitory peptide, which inhibits the gastric secretion and motility. It says, okay, stomach, you've done your job, stop. This is an interesting thing about the gastric inhibitory peptide. They're looking at the GIP, okay, gastric inhibitory peptide, and there's a couple different types. And what they found was, when they looked at Gila monsters, of all things, when they looked at Gila monsters, they looked at their gastric inhibitory peptide, because Gila monsters eat only a couple times a year, because their GI motility is exceptionally slow. So what they're looking at in diabetic patients is possibly to slow their GI motility, to let things sort of catch up a little bit, by using medications that are analogs or taken from this GIP, which might be something that you'll see a little bit more down the road. Okay, but this GIP tells the stomach, hey, slow things down, because you're done. Your job's over. We don't need anything else happening. Also, with the stuff getting into the intestine now from the pylorus, there's a release of secretin, and secretin decreases all the other gastric secretions as well. So the stomach is going on a hiatus. It's going on a break at that point. Also, what happens is there's another chemical that's eventually released, which is called cholecystokinin. Cholecystokinin. And what cholecystokinin says, okay, the stomach's empty. There's no sense in trying to empty more that ain't there, and it actually stops the stomach emptying. Okay, so this nerve stimulation and then results in this enterogastric reflex, which results in inhibition of all the parasympathetic fibers as well to the stomach and stuff. So we decrease what the parasympathetic fibers to the stomach. Acid secretion, blah, 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 the motility, the squeezing, so all that stops. So that's what we call the intestinal phase, where we're now past the stomach, and the stomach is basically shut off by cholecystokinin, secretin, and gastric inhibitory peptide, as well as feedback to the area of the medulla oblongata saying, okay, we don't need any more activity in the stomach. We're going to need it down the intestines, though. Be ready, because we're going to need it down the intestines. And that's what we see with the intestinal phase. Okay, so what we've talked about in this video is talked about what happens from the mouth to the stomach. It's, again, pretty interesting, a lot of stuff that's going on in there. And so hopefully if you have any questions, you could answer those, ask those questions in regards to that. What we'll also be doing is we'll have another video that will come up after this one, which will be gastrointestinal 3. This will be gastrointestinal 2, which is basically now what happens once that material gets in the small intestine and goes through the large intestine. And we'll talk about the intestinal activity, the lower gastrointestinal tract, and then we'll have GI 4, which will talk a little bit about what the stomach does, what the pancreas does, what the gallbladder does, and all these ancillary organs that we have in the abdominal cavity, which add their little input. Okay, so I think that's enough for now, and we're going to stop. And again, if you have any questions about anything we talked about, by all means, email me or ask me at one of our meetings or whatever the case may be. Anyway, have a good evening.